in the field of aging. She is the director of the Center for Research on Health and Aging and professor of community health sciences at the University of Illinois at Chicago School of Public Health. She designed the award-winning evidence-based Fit and Strong physical activity and behavior change program for older adults with arthritis. In this webinar, she will discuss her past and current research around the Fit and Strong program. So welcome, Dr. Hughes.
Thank you so much, Allison, and I wanted to thank so much everybody on the webinar today. We are just delighted to have this opportunity to share what we've been doing with Fit and Strong with all of you. So I want to just kind of say, good morning to folks on the West Coast and good afternoon to folks on the East Coast, and we'll get right into the presentation because we don't have too much time to spare. So moving right along, I do want to just say one thing briefly, and that is that I am recovering from a cold. So if my voice gives out, kind of during the presentation, we do have backup support here. Drew DeMott here, who is our Fit and Strong project manager and center coordinator, who can jump in if that happens. So I want to just get started with the goals of the presentation. Today we want to review the development of the evidence base for Fit and Strong. We want to quickly review some practical implementation issues. Then we want to talk very, very briefly about an ongoing CMS evaluation of our program and several other evidence-based programs. And then very briefly discuss the new diet version of the program that is being tested in the field. So to get into the development of Fit and Strong, the reason why we want to talk about this is we want to make it clear why we designed the program to have the components that it has. And so it's important for folks to understand that Fit and Strong builds on the findings from an earlier prospective longitudinal study of 600 older adults in Chicago. So these folks were measured at baseline 2 and 4 years, and what we found, two things. First of all, arthritis is the #1 cause of disability in this population, and second, lower extremity joint impairment in particular is a risk factor for future disability. So we had measures of all the joints in the body, divided them into upper versus lower, and found that lower extremity joints were the culprit in terms of disability. This makes sense when you think about the fact that people use these lower extremity weight-bearing joints to do a lot of activities of daily living, like getting in and out of a bathtub, climbing stairs, getting in and out of a car, etc. So once we discovered the link between presence of OA in lower extremities and future disability, the question arose how to break the chain. And we were very curious about whether physical activity was the answer. So what we did is we looked at the then existing OA literature on physical activity, and we found, reading that literature, that people with osteoarthritis have two problems. The first is that they have decreased aerobic functioning, and the second is that they also have decreased muscle strength compared to age-matched controls. So basically what this points, what we think is the explanation for these findings, is that pain in lower extremity weight-bearing joints causes people to stop their activity. So if they stop moving around due to pain, that leads to the adoption of a sedentary lifestyle, which further leads to deconditioning, increased stiffness, increased pain, and it's basically a vicious cycle. So what all of this implies is that new interventions must really address all of these deficits. So they must include flexibility, aerobic conditioning, and strength training if they really want to have break this chain. So in addition to the physical activity components of the program, we also wanted to design a short-term program, but one that had long-term impact, if at all possible. So we also read up on the adherence literature. And adherence literature, and specifically social cognitive theory, basically states that it's critically important to include an education component in the program to increase people's self-efficacy. So I'm sure most of you on the phone know what self-efficacy is. So there are two really important components. The first is confidence that you can perform a task, and the second, that sometimes is not as well recognized or remembered by people, is the belief that if you perform it, you will achieve a personally meaningful outcome. So personally meaningful means something that matters to you as an individual, not something that your doctor tells you to do, and not something that your spouse tells you to do, or anyone else in your family tells you to do. It's something that matters to the individual. Social cognitive theory also suggests that there are tips that you can use in designing a program. One of them is to make the exercise as easy to do as possible. We know that people love to walk, so we basically featured walking for the aerobic component of the program. Also helps it's important to help participants develop individualized routines, to provide structured reinforcement regarding their progress as they go through the program, and to use group and facility-based programming to provide social support, and also peers. The role of peers to reinforce exercise behavior is very important. If people with painful OA go to Gold's Gym and they see, younger folks, jumping around in spandex and so on and so forth, they don't find that very motivating, because it really makes them worried about whether that would harm, their joints instead of helping them. So Fit and Strong is different. It combines physical activity and education for lifestyle change. The physical activity component is multiple component, and we specifically target people who have lower extremity pain and stiffness. The program lasts 8 weeks, and it meets 3 times a week. Each session is 90 minutes long. So the first 60 minutes of the program are devoted to physical activity, and the last 30 minutes are devoted to the group discussion, problem solving, following a structured curriculum. We then, in week 6, we have another component to the program, which is a negotiated adherence contract that the instructor performs with each individual. We'll talk about that more later. So why do we call it an evidence-based program? We call it evidence-based because we tested this in a randomized controlled trial that looked at several outcomes, including lower extremity disability, pain, and stiffness, some performance measures, and also self-efficacy. And our key outcome was exercise participation at 2, 6, and we went out to 12 months. So here are the significant outcomes that favored the treatment group. Importantly, there were no untoward effects in the treatment group. You can see at 2 months we had a significant impact on adherence, which is engagement in physical activity. We also had a significant impact on self-efficacy for exercise and diminished lower extremity joint stiffness. So we continued measuring people at 6 months. Several other outcomes became significant. Time adherence for efficacy became significant, as well as several pain management and pain measures. Here are the effect sizes for the same outcomes, and most of you probably on the call understand that effect sizes are basically for a pharmaceutical intervention that's been approved by FDA. A typical effect size ranges from about a 0.2 to a 0.4. So here are effect sizes for self-efficacy, and you can see that they're pretty substantial. They're in red. If you go down to the bottom of this slide and look at total exercise minutes, which is adherence, again, these are pretty substantial effect sizes that are maintained over time. So we conclude from all of that the benefits we're seeing at 2, 6, and 12 months, that this is, I guess we're losing a little bit of this slide. I'm not sure quite why. This is a non-pharmaceutical intervention with substantial effect sizes for several outcomes. We saw no untoward outcomes, injuries, or effects, and published the baseline 2 and 6-month findings in the 2-month 2004 issue of the Gerontologist, and the final findings in 2006. So moving right on, while we were doing the efficacy trial, we obtained funding to do a follow-up effectiveness trial to test 4 different ways of bolstering maintenance to fit and strong after the 2-month program ends. So this study was funded in 2003, and we were able to add 536 older adult participants to our database and replicate the program in 7 Chicago Department on Aging senior centers, including several on the south side of Chicago. This also enabled our outcomes to be extended out to 18 months. So here are the findings from the effectiveness trial. We did not have any significant differences by maintenance group, so we have just combined all of the outcomes, for the group as a whole here. And you can see that our primary outcome, which was physical activity, we had a significant improvement in frequency of physical activity at 2 months that was sustained at 6, 12, and 18 months. The same thing occurred with respect to frequency of moderate physical activity, which is really our target for this group. We're not really trying to get people, who have lower extremity osteoarthritis to engage in vigorous physical activity, but moderate physical activity is really more appropriate. So here are other outcomes, and what this is basically telling us is that if people continue to engage in physical activity, other good outcomes will also be affected. So here we're looking at lower extremity stiffness, pain, and function. We're looking at strength and mobility and depression and anxiety, and many of those were significant 2 months and were maintained over time. We've highlighted lower extremity strength and mobility at 18 months. And the reason why we've highlighted those is these are timed performance measures. So the lower extremity strength measure is the sit-stand measure, and the mobility measure is the 6-minute distance walk. Why do these findings matter? They matter because diminished lower extremity strength is a risk factor for falls. Impaired mobility is also a risk factor for falls and an independent risk factor for mortality. So we now have very solid evidence showing that our 8-week program impacts 2 very important risk factors out to 18 months. Another important thing to note is that walking speed decreases just naturally over time with age. Fit and Strong has been able to reverse this trend in a group that's at high risk for disability at enrollment. So we conclude from the efficacy and the effectiveness trials that Fit and Strong is low cost, fun. People really love it, want the program to keep on going. It's easily replicable and impacts the outcomes shown here. Importantly, the benefits are maintained at 2, 6, 12, and 18 months, and the benefits are consistent now across increasingly diverse participants, instructors, settings, and geographic areas. And that's the true hallmark of an evidence-based program. Those findings were published in 2010. So now I'd like to turn to the dissemination and translation study. While we were getting the effectiveness study completed, we were able to write a grant and get funded by CDC with an R18. An R18 is a great grant because it enables you to test the translation of Fit and Strong. It enabled us to do that in 2 states, in Illinois and North Carolina. So this enabled us to do all of the really wonderful things that you need to do if you're getting into translation mode with a program. So we were able to develop an interactive website to track attendance and participant outcomes, to develop implementation guidelines for the sites and procedures to assure program fidelity, and also able to develop the trainings for our T master trainers and instructors, and finalize very important instructor and participant manuals. So here are the findings from the dissemination phase of the program, and this is out in the field, and these are our baseline and 2-month outcomes for the first 300 participants that were involved in the R18 in Illinois and North Carolina. And we used some different outcomes that basically assess the same features, but are easier for instructors to use in the field. And here you can see that we are also showing significant outcomes, on these at 2 months. So moving along, want to shift now. That's the evidence base. Want to talk now about what we need to implement Fit and Strong. So one of the first things we want to talk about is space. Lots of people, have questions about the size of the classroom or space that's needed to do the program. And that really, the class size or the number of participants really depends on the room size, the number of instructors that you have, and the ability level of the participants. We find that the people who enroll in Fit and Strong are very heterogeneous with respect to their ability levels at baseline. We recommend that 20 to 25 participants per class is ideal. It's very important for participants to be able to stand and extend both arms laterally without touching their neighbor. It's also important to have some storage space for equipment. So that brings me to equipment. The good news is our equipment is really simple. We use the elastic exercise bands or tubing. Most of you are familiar with. We use ones that have integrated foam handles. That's because many of the people in our class who have lower extremity OA also have upper extremity, and we want this to be a very safe experience for them using the bands. We also use adjustable ankle cuff weights. So these cuff weights range in from 0.5 to 10 pounds. They come in half-pound increments. Those are basically like lead rods, and we call them hot dogs. So we usually assign one cuff weight per participant at the beginning of class, customize the fitting of the ankle cuff weight in the first class, and then the instructors are trained to ask people to advance the weight weekly. We also use exercise floor mats. We do get people down on the floor. We try to get as many participants as possible to learn how to get down on the floor safely in about week 3 to 4 of the class, and also learn how to get back up safely. This is something that's very important. A lot of the folks in our class are living alone at home, with OA. They're very frightened that they might fall, find themselves on the floor, not know how to get up safely. We also, the very important part of the equipment is our instructor and participant manuals. Talk about that more in a second. So who are our instructors? We use certified exercise instructors. These are people who are certified by one of many national certification bodies like the ACSM or ACE. We can also train persons who have significant exercise backgrounds. So, for example, physical therapists or PTAs. And we can also train people who have been certified in other evidence-based exercise programs. So, for example, chronic disease self-management, matter of balance, or the Arthritis Foundation exercise program. Another important feature of the program is our group discussion problem solving. So the manual covers, the participant manual covers 24 health education topics. We start with what is OAA, what is the relationship between OAA and disability? Is there anything that you can do to prevent becoming disabled over time? How can exercise help? What is a safe routine? So on and so forth. So the point of the manual is to boost participants' confidence in their ability to exercise safely with arthritis and develop skills to maintain a physically active lifestyle. The physically active is underlined because we're not just talking to them about continuing to do the exercises that they learn in class, but thinking about what is available to them in their environments. So, for example, if they have stairs in the house and they need to use those stairs to go down and do the laundry, that's a good exercise opportunity. And, climbing those stairs is going to be good for them. And, we all know the other tips about, parking your car farther away at the mall and, walking to the post box and so on. The other thing that we try to do is increase participants' knowledge about how to use physical activity strategically to manage their arthritis, that they, if they have a flare-up, they just take it easy for a day, but they get back on the horse. So you spend a lot of time talking about dealing with barriers. So we also have an important feature of the program called participant adherence contracts. In week 6 of the program, the participant and the instructor meet. The instructor is now acting like a coach to help the person develop a negotiated adherence plan. So this is a tailored adherence plan that includes flexibility, aerobic, and strength exercises, but the instructor sits down and goes over with the participant, where are you going to do it? What are you going to do? How are you going to do it? When are you going to do it? Do you want to do it alone? Do you want to do it with a buddy? Do you want to do it at home? Do you want to do it at a facility? So it's a very tailored plan that reflects their preferences and also the availability of resources in their immediate neighborhoods. This plan is a signed contract for post-Fit and Strong maintenance that people take home with them in the last day of class. So here's our some recognition that the program has received. We are now recommended by the Arthritis Division of CDC, by the National Cancer Institute, RTIP's website, the National Council on Aging, Administration on Community Living, and by the American Physical Therapy Association. And we're very, very proud to have been the recipients of the ASA Pfizer Healthcare and Aging Award in 2008 and the APHA Archstone Award in 2006. So touching very briefly on the CMS evaluation, CMS is the Centers for Medicare and Medicaid Services, and they have been mandated by Congress as part of the Affordable Care Act to evaluate evidence-based wellness programs. So they are examining the health and well-being of participating beneficiaries and cost outcomes for those beneficiaries for Medicare. So this evaluation may lead to Medicare reimbursement for Fit and Strong down the road, and also for other evidence-based programs that are participating in the evaluation. And that is in the data analysis stage right now. I want to just very briefly talk about our new weight management version. So this new version came about because when we were doing the effectiveness trial on the south side of Chicago, we worked with a number of older African-American women who asked for more help with diet, weight management. So we went back to drawing boards, looked at the literature on obesity and OA, And we found that OA symptoms are exacerbated by obesity, weight loss of modest weight loss to 5.1 kilograms can decrease the odds of developing EOA by more than 50%, and also that a 10 to 15% weight loss by overweight or obese adults can result in a decrease in lifetime Medicare expenditures ranging from about $10,000 to $16,000. So the new weight management version, the important thing about this is that currently no evidence-based program combines physical activity with weight loss. The science has shown, that the combination of these two approaches makes a difference, but currently no evidence-based program that is translatable exists that addresses both. We are now spending, in 2009, we spent $42.2 billion on joint replacements in the United States. So this is an important issue. So the current NIH trial that we're doing of Fit and Strong Plus, physical activity plus diet weight management is close to complete. Let's see. Oh, that basically completes it for us, and I hope we still have some time for some questions.
Thank you, Dr. Hughes. That was a great presentation. We will still have a question and answer session, but if you do need to log off, we understand. Briefly, just a reminder, we have a webinar next month, May 17th, with Dr. Portia Flowers, who will be discussing her research in racial differences in joint hypermobility, injury, and osteoarthritis. But now we can ask any questions that you all have. I know we had some technical difficulties at the beginning for a few of you, so apologies for that. Thank you for sticking with us. We will have this recorded on our YouTube channel in its entirety. I have a question just to start us off. Oh, wait, here's one question coming in. Can you tell us a little more about the weight loss and, can't see the rest, and exercise program?
Well, what we have done is we have taken some material that we think from the manual that we think is redundant, and we have replaced it. Repetition is a good thing, but we basically decided maybe we could take some of that out and replace it with new information about diet and weight management. So we have homework assignments, we have dietary aids, we teach people how to read labels, we teach them how to put together shopping lists, how to approach a store in their neighborhood, to go around the outside aisles. We also give them a lot of homework assignments. We use dietary recall, and then we also have these homework assignments to bring health aid, to bring labels to the class for discussion, and to bring successful recipes that they have tried. And in the last class, they basically bring in a little cookbook that they've put together. So that's how we do the regular physical activity routine for the physical activity part of the program. The thing that has changed is the health education component has been broadened to systematically address diet and weight management. Does that answer your question?
Yes, it looks like it answers the question. And I have another question. Do you have any tips for Fidelity for implementing Fit and Strong and other evidence-based programs?
Well, the important thing when we do our training is we focus very, very, very heavily on core components of the program and trying to make it very, very clear to trainees what those core components are. We usually do an in-house audit of the program, a site visit to assess Fidelity. I think that, the important thing is that if instructors can understand the relationship, that, if they do the program as it was originally designed, it's pretty much guaranteed to show positive outcomes over time, and that is really where the field is moving. That is where reimbursement is moving. That's what managed care plans are looking for. And so, I think that organizations that want to be doing quality work, this is really where they want to be. So that, I don't know if that helps with your question.
Yeah, no, that was great. Thank you. Do we have any other questions? I don't have any, oh, maybe, yes. Yes, you have a question? Looks like we might have another question coming in. So do you know when the Fit and Strong Plus trial will be completed?
Pretty soon. We are basically putting together a manuscript now with the 2 and 6 month findings. So we have finished doing the implementation of the program in the field. We're now doing, because we're again going out to 18 months with findings, it's taking a while to complete the data collection.
Great.
Any other questions?
Yeah. Any other ones? If not, thank you for joining us today, and we will hopefully see you all next month for our next Lunch and Learn. So thank you for tuning in, and thank